Hello, class. Welcome to week 5. I'm still getting this up in time, but my apologies for being a little bit later than I have been over the last month. So this week we are going to discuss mood disorders, more specifically, those categories of bipolar disorders, which inherently have aspects or characteristics of ups or mania, but not always meeting criteria for mania, and downs, which would be depressive symptoms, but again, not necessarily meeting criteria for a depressive episode or a depressive diagnosis. So we're going to be looking at bipolar disorders as well as depressive disorders in particular. All right, like I said, bipolar and related disorders, these are largely experiencing symptoms of not happiness. That's not what mania is. So symptoms of being up or characteristics of being up, and then that oscillating with symptoms of being down or having some depressive characteristics. So bipolar 1 disorder is the first that we will look at. So remember that essentially the differentiating factor or characteristic criteria for bipolar 1 disorder is that the individual has met criteria for at least one manic episode. So that's what makes this different than any of the other diagnoses, particular bipolar 2 disorder. So criteria B for this is the occurrence of the manic and major depressive episodes are not better explained by some of the diagnoses that we talked about or characteristics that we talked about last week of schizoaffective disorder, schizophreniform, and delusional disorder, or other or unspecified schizophrenia spectrum. So when you are meeting with an individual who may be talking about feeling up and down in their mood, a screening question you could ask is, do you have mood swings, sometimes way up, other times way down? And you'll see how this question is just a little bit different in bipolar 2 in coming slides. So as I said, bipolar 1, the characteristic here that you're looking for is meeting criteria for a manic episode. So this is a distinct period where the person is abnormally and persistently elevated. And remember that mania isn't necessarily just happiness. It can be irritable. Mania can take a lot of different it can look very different and manifest very differently, present very differently with people, but you're really looking for it's persistently increased. There's increased activity and energy that is notably different from a person's kind of baseline mood. And what it needs is, it significantly affects their functioning. So again, this is what differentiates mania from hypomania as well. So you are also looking for at least 3 symptoms of these 7 listed here that the person is presenting with. So inflated self-esteem or grandiosity. So thinking that they're, very important, that their abilities are maybe beyond what they really are. Decreased need for sleep. So this is the most common feature, and many people who present or who initially come to therapy or to get an assessment for bipolar or other mood disorders come asking about or complaining about issues with sleep patterns. So they're more talkative than normal, and maybe the cadence that they are talking is a little bit quicker than they have historically had. Flight of ideas or subjective experience that thoughts are racing. This can also be where you're having a little bit of trouble following the logic of an individual's thought process or how they're sharing their thoughts. So distractibility, where they have their attention in many different areas. And sometimes it is with a seemingly unrelated stimuli. They have an increase in goal-directed activity. So this is where they may, open a new business and stay up for several days figuring out the logistics of an LLC, or they are they stay up for they decrease sleep and stay up a lot to plan a gathering or something like that. So the goal-directed activity is important here because that's also a differentiating characteristic than some of the schizophrenia disorders that we covered last week. And then excessive involvement in activities that have high potential for painful consequences. So these can be things like gambling, like it says here, sexual indiscretions, investing money in places that are very risky, or potentially investing more money than the person could afford to lose, buying a lot of, accumulating a lot of goods. And as it says at the bottom, the manic episode must result in marked impairment in social or occupational functioning or require hospitalization. So it can be one or the other. And also, by definition, the presence of psychotic features during a manic episode also does satisfy criterion C, which is the impairment in occupational and social functioning. So there's mania, and then there's major depressive episode. So these are the 9 potential criteria for the individual to meet. So again, bipolar 1 is a meeting criteria for a manic episode, and then meeting criteria for a major depressive episode. So you can see here those 9 criteria that you are looking through to see if they do meet criteria for a major depressive episode. So as you can see, things like depressed mood for most of the day, nearly every day, as indicated by either a subjective report or observation from others, marked diminished interest or pleasure in all or almost all activities. And this can also be diminished interest in activities that, this is diminished interest in activities that the person used to find pleasurable. This is what is anhedonia, significant weight loss when they are not attempting to lose weight, or weight gain when they are not purposely attempting to gain weight. And then loss, which is usually accompanied by a loss or increase in appetite. So again, it's just different than baseline. Insomnia or hypersomnia. So again, major depressive episodes, I think, are kind of stereotypically seen to be correlated with a bunch of sleep. But sometimes it is no sleep, or sleep at kind of going against a circadian rhythm. So maybe they are awake during the night and sleep for bits during the day. So again, any sort of sleep pattern disruption. And this is, again, one of the major reasons that people seek any treatment or seek an assessment. So if the individual's psychomotor functioning is either agitated or it's really slowed, this can be a sign: fatigue or loss of energy. Again, this has to be persistent nearly every day. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. Diminished ability to think or concentrate, being indecisive nearly every day, more so than usual. Recurrent thoughts of death, not just fear of dying, recurrent suicidal ideation without a specific plan, a suicide attempt, or a specific plan for completing suicide. So any sort of suicidal ideation needs to definitely be prioritized in the assessment and addressed. So in terms of just some statistics, when the DSM covers prevalence, development and course, culturally related diagnostic issues, and then suicide risk. So bipolar 1 disorder is experienced by about 0.6% within the continental United States. So I don't know what is going on with Hawaii and Alaska. And it is a little bit more common in men than women. As we know, the DSM is informed by research, and non-binary identity is still hopefully being incorporated a little bit more into our research. So the language around gender identity within the DSM is quite binary, as it reflects just how we are conducting and how we're gathering data from humans. So the mean age of onset for the first manic, hypomanic, or major depressive episode is approximately 18 years for bipolar 1 disorder. And then in terms of diagnostic issues, for bipolar 1 disorder, we don't have much information on specific cultural differences in the expression of bipolar 1 disorder. As we know, the DSM is culturally bound. So we really have one understanding of how it looks. So just really making sure that you're asking these culturally competent, culturally conscious questions. And a possible explanation for this is, again, the DSM is informed by research, and our diagnostic instruments are how we get this research information. And our diagnostic instruments are generally created for, like, the language is used with more highly educated individuals. It can be pretty ethnocentric, especially if it is created in the United States. And so we have these diagnostic instruments that may not be culturally relevant in terms of the questions that they ask, the language that is used. And I don't just mean like it being in English. I mean like terminology that doesn't really translate, or that doesn't really have a cultural equivalent. So potentially the instruments are, or as we know, instruments are often translated and applied in different cultures, but there's no transcultural validation. So again, it's not just about translating the actual words from one language to another. It's is there a like a cultural understanding or a cultural phenomenon that is relevant to that culture that is asked in the diagnostic instrument. So having something be culturally relevant is more than just a language translation. Then suicide risk. So lifetime risk for suicide in individuals with bipolar disorder is 15 times that of the general population. And bipolar disorder may account for 1/4 of all completed suicides. So the suicide assessment, when there is like suspicion or the client is meeting criteria for bipolar 1 disorder, is incredibly important to assess for suicidal or risk of suicide, and have a safety plan, or potentially act immediately and have that person put into into like treatment or into services that can be immediately helpful for the individual. If you go through the suicide assessment and find that they have a plan, they have access, they have means, they have all of the criteria that would need to be met for immediate intervention. So then we're moving on to bipolar 2 disorder. So this is differentiated by determining whether there have been past episodes of mania. So remember, bipolar 2, the person cannot meet criteria for a manic episode. They can only meet criteria for a hypomanic episode and at least one major depressive episode. So again, there has never been a manic episode. If they do have experienced a manic episode, they meet criteria for bipolar 1 disorder. And as with bipolar 1, the occurrence of that hypomanic episode and the major depressive episode is not better explained by any of the diagnoses that we talked about last week. Criteria D for bipolar 2 disorder is that the symptoms of depression or the unpredictability caused by frequent alternation between episodes in depression and hypomania cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. A hospitalization is not necessary for bipolar 2. Again, if the person does need hospitalization, they would meet criteria for bipolar 1 disorder, because likely the symptoms would be more than what would be needed for hypomania, and it would be a manic episode. So when you have a person who is in your office where you are practicing, a screening question here is, it's very nuanced. So the question for bipolar 1 was, do you have mood swings sometimes like way up and other times way down? So you can hear the kind of larger nature of the swings in the mood. And then here for bipolar 2, it's sometimes going up and other times going down. So it is nuanced in the language of that screening question. So hypomania, looking over a few of the diagnostic criteria here. Criteria C is the episode is associated with an unequivocal change in functioning that is uncharacteristic of the individual when not symptomatic. So again, if you are comparing criteria C, D, and E with that of a manic episode, you can see how they are different. D, the disturbance in mood and the change in functioning is observable by others, and the episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. If there are psychotic features, the episode is by definition manic, and therefore the diagnosis would be bipolar 1 disorder, because they would meet criteria for mania and not hypomania. So this is similar. So the differentiating feature of bipolar 2 is the hypomania, but the major depressive episode can be exactly the same as with bipolar 1. So same 9 criteria here for a major depressive episode. But again, the difference is hypomania for bipolar 2, mania for bipolar 1. And as it was stated in, I think, all of the texts for this week, I think a dangerous way to kind of conceptualize the difference between hypomania and mania is that hypomania is like a less severe experience of mood changes or mood swings, because I think that you run the risk of minimizing or dismissing the difficulty of what bipolar 2 symptoms and how they affect the individual. So I encourage you to not look at like hypomania as like mania light or anything like that. It is just as distressing. The pendulum may not swing as big, but to say a like less severe, I think is doing the like the effects and the lived experience of hypomania disservice. So with some prevalence and all that kind of stuff for bipolar 2, it is so of the 12-month prevalence internationally is 0.3%, and then in the United States, the 12-month prevalence is 0.8%. So just a little bit different than the prevalence for bipolar 1. With bipolar 2, the average age is in one's mid-20s. So that's slightly later than bipolar 1 disorder, but it is also earlier than for major depressive disorder. So what can happen with this diagnosis is that it begins with a depressive episode and it's not recognized as honestly either bipolar 2 or bipolar 1 until that episode of hypomania or that episode of mania occurs. So with both bipolar 1 and 2, people generally come in again with the distress and the difficulty with a major depressive episode, because maybe they don't, particularly with hypomania with bipolar 2, the episodes of hypomania, because they may not experience, then they don't experience the necessity for hospitalization, and maybe their functioning is not so interrupted that they don't even necessarily recognize that they have had a hypomanic episode. So when this happens, when somebody comes in for a major depressive episode, about 12% of individuals have an initial diagnosis of major depressive episode that then they experience a hypomania episode. And then their diagnosis changes to bipolar 2. So suicide risk is quite high in bipolar 2. Approximately 1/3 of individuals with bipolar 2 disorder report a lifetime history of a suicide attempt. So again, very important to assess this and to act and treat accordingly. So then we'll talk about cyclothymic disorder. So this is happens over a longer period of time. So for at least 2 years in adults and 1 year in children and adolescents, there have been numerous episodes of hypomanic symptoms that do not meet criteria for hypomanic episodes. So again, that's why at the beginning of this, talking about bipolar, just like the bipolar disorders in general, that they're not necessarily hypomanic or manic episodes, that they're hypomanic or just manic symptoms. So they don't necessarily meet criteria. And then numerous episodes of depressive symptoms that do not meet criteria for major depressive episodes. So again, this is numerous periods. So individuals who are diagnosed with bipolar 1 and bipolar 2 may not cycle through or have multiple episodes of manic or hypomanic and major depressive episodes. Cyclothymic by nature is cyclical, in that they have multiple episodes of this and that they have been experiencing them for at least a 2-year period. So criteria B for cyclothymic is that during that 2-year period, the hypomanic and depressive periods have been present for at least half of the time, and the individual has not been without symptoms for more than 2 months at a time. So over that 2-year period, they have not been symptom-free for more than 2 months, and that for at least a year of that 2-year time, or at least 6 months of that 1-year time for children and adolescents, they have been experiencing symptoms of hypomania, or symptoms that don't quite meet criteria for hypomania and major depressive disorder, but they've been hypomanic and depressive in nature. So again, highs and lows. As I stated before, criteria for a major depressive, manic, or hypomanic episode have never been met. And then criteria D is that the symptoms of criteria A are not better explained by the diagnoses that we talked about last week. And the symptoms are not attributable to a physiological effect of a substance or a medication. So this is really going back to week 1 of that differential diagnosis, really looking at substance use or medication use and looking at history of medical diagnoses or any sort of medical issues that the person has been experiencing. And the criteria F is that symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. As mentioned before, clinical significance is subjective. So that really is where you engage in the client in a dialogue around their level of distress, how these experiences of mania and these experiencing symptoms of mania and depression, how they have been affecting that individual socially, occupationally, and then in other areas that are important to that person. So the essential feature of cyclothymic disorder is chronic fluctuating mood disturbance involving numerous periods of hypomanic hypomanic symptoms and periods of depressive symptoms that are distinct from one another. So these hypomanic symptoms are of insufficient number, severity, pervasiveness, or duration to meet full criteria for a hypomanic episode. And the depressive symptoms are also insufficient in number, severity, pervasiveness, and duration to meet full criteria for a major depressive episode. So a screening question here would be, do you have constant mood swings alternating from high to low? In terms of prevalence, cyclothymic disorder is experienced in approximately 0.4 to 1% of the population. And so the symptoms usually begin in adolescence or early adult life and is sometimes reflects a temperamental predisposition to other disorders that are in the bipolar and mood disorders section of DSM. This is usually has an insidious onset and persistent course. So there is a 15 to 50% risk that the individual with cyclothymic disorder will subsequently develop bipolar 1 or bipolar 2. So they will eventually meet criteria for either a manic episode and a major depressive episode for bipolar 1, or a hypomanic episode and a major depressive episode for bipolar 2. Comorbidity with cyclothymic disorder may be present in individuals. So having substance related issues or sleep disorders, so difficulty in initiating and maintaining sleep, may be present in individuals with cyclothymic disorder. So again, depending upon if you haven't taken chemical dependence, these theories will make more sense, but substance related disorders. So it may be that their mood is affected by the use of substances, or that they are self-medicating. These aren't the only two, but these are two possibilities, is that they're with substance related disorders, there can be a self-medication component to it, as we've talked about generally with more manic symptoms. The individual would use depressants to kind of try to slow back down to baseline. It's like a helping of the natural systems within the body of regulation to try to return back to a baseline or some level of homeostasis. Or with those depressive symptoms, individuals may take stimulants again to try to reactivate or increase some activity in the body and some of those, neurotransmitters and that neurophysiology. And then sleep disorders with this can absolutely be affected by mood. So I share this to make sure that you are assessing for, is this a consequence of substance use, or is this something where the symptoms preceded any sort of substance use, potentially with the substance use being an attempt to regulate. So then moving to the depressive disorders, the common feature of, so you can see all of the list that I'll be covering in the rest of this presentation. The common feature is the presence of sad, empty, or irritable mood accompanied by somatic and cognitive changes that significantly affect the individual's capacity to function. But what differs in all of these is the duration, timing, and presumed etiology. So disruptive mood dysregulation disorder, as you guys know, Dr. Francis is not a fan of this, but as we always encourage you to do, to kind of come to your own conclusions about this and kind of look at the history of how, like, where this diagnosis came from. But this so this is a pediatric, sorry, I lost my train of thought for just a second. This is a pediatric diagnosis. So this refers to the presentation of children with persistent irritability and frequent episodes of extreme behavioral discontrol. This was added to depressive disorders for children 12 years of age, up to 12 years of age. So as we read, kind of the timing of diagnosis for this is between 6 and 12. So depressive disorders are by nature unipolar, so they do not have the manic symptoms. So they're unipolar depressive disorders or anxiety disorders. So again, this is differentiated from the bipolar disorders that have both a manic and a depressive piece. There is a high rate of comorbidity with other diagnoses. As we read, and that would be also needing to be differentiated between. So the core feature of DMDD is chronic, severe, persistent irritability. So as we know with like a diagnosis like ODD, that is a clear or intermittent and explosive disorder, where these features are clearly different than like baseline, but disruptive mood dysregulation disorder is pretty persistent. And that is the core feature and the differentiating feature here. So there is severe irritability that has two prominent clinical manifestations. The first is frequent temper outbursts. So these typically occur in response to frustration and can be verbal or behavioral. And then a chronic, persistently irritable or angry mood that is present between the severe temper outbursts. So this must be this chronic, persistent irritable and angry mood should be characteristic of the child, being present most of the day, nearly every day, and noticeable by others in the child's environment. So again, that persistent irritability is the differentiating is a differentiating feature with DMDD. So the onset of DMDD must be before age 10, and the diagnosis should not be applied to children with a developmental age of less than 6 years. So as we know, sometimes chronological age is different from developmental age. So there is some clinical assessment that needs to be done here to see developmentally where the child is. And then I wanted to list all of the differential diagnoses here and how they differ from DMDD. So with bipolar disorders, the central feature that differentiates DMDD and bipolar disorders in children involves the longitudinal course of the core symptoms. So having this mood be perturbed that occurs during a manic episode is distinctly different from the child's usual mood. So you can see DMDD is persistent. It is not different from the child's usual mood. So if there is something that's different there, you should be looking at the decision tree for bipolar disorders as opposed to DMDD. So ODD, there are symptoms of ODD that occur in children who have the diagnosis of DMDD, and mood symptoms of DMDD are relatively rare in children with ODD. So ODD symptoms usually occur in DMDD, but DMDD symptoms are very rare in children with ODD. So if the child meets criteria for both, only DMDD should be diagnosed. So even though they may have symptoms and meet criteria for both, only DMDD would be diagnosed. So attention deficit hyperactivity disorder and major depressive disorder, any sort of anxiety disorders, and autism spectrum disorder. How DMDD is different is that children whose irritability is present only in the context of a mood episode would not receive the diagnosis of DMDD. So again, this is a manifestation that is characteristic of the child. It is basically always present. And then intermittent explosive disorder. Intermittent explosive disorder does not require persistent disruption in mood between outbursts. So intermittent explosive is, again, there's this kind of baseline for the child, and when they are in an episode, it is clear that it is different. So then we have major depressive disorder. So these can be discrete episodes of at least 2 weeks duration. Many episodes last longer than this, but the minimum is 2 weeks. And quite frankly, that was put in place as an assessment piece, but it stuck. So at least 2 weeks. And major depressive disorder is generally recurrent. So the risk of recurrence becomes progressively lower over time as the duration of remission increases. However, it also does go the other way. So recurrence is more likely when there has been more episodes. So the criteria must be met and present nearly every day to be considered present, except for weight change and suicidal ideation. Those are the two criteria that don't need to be present every single day to meet criteria. Then depressed mood must be present for most of the day, in addition to being present nearly every day. So present most of the day, nearly every day. And as I mentioned before, with both bipolar and unipolar depressive disorders, that insomnia or fatigue is usually the presenting complaint. So if you hear that, make sure that you remain open to all of these possibilities of a potential bipolar diagnosis or a unipolar diagnosis. So you want to, if you are not probing for any of the accompanying depressive symptoms, you likely will miss a potentially helpful diagnosis. So again, as we know, diagnosis is kind of a double-edged sword, where it can be stigmatizing, but it also can help an individual access resources that would be really helpful for them in moving through and navigating healing, however, recovery, however you want to label moving through the diagnosis. So in terms of prevalence, major depressive disorder, approximately 7% of people within the United States have this, and there are marked differences in age groups. So the highest prevalence, so this may be, so this is a kind of an average, right? So it may be that like 20% of 18 to 29-year-olds have a diagnosis or meet criteria for major depressive episode, whereas individuals who are 60 or older, they might be like 1%. So you can see individuals have a threefold, 18 to 29-year-olds are threefold higher in their prevalence. So just know that it's a bit of a bell curve in terms of diagnosis for this. And then females experience 1.5 to threefold higher rates than males beginning in early adolescence. So, I mean, take that for what you will in terms of genetics or societal stuff. And then the likelihood of onset increases a lot with puberty. And then in terms of genetics and physiological features, first-degree family members. So a person that shares at least 50% of their DNA with the individual. So first-degree members that have major depressive disorder have a risk for major depressive disorder 2 to 4-fold higher than that of the general population. So this is something that is definitely believed to have a genetic component to that. So again, if you have somebody who's coming in to you presenting maybe with things like insomnia or fatigues, a screening question for major depressive disorder would start with, do you ever get so depressed that you can't function? So the readings for this week were very clear in differentiating between grief and a major depressive episode. So sometimes what we do, particularly with grief, or honestly kind of what we do as a society, is we pathologize really common and normal human experiences, and grief is one of these. In the DSM-5 text revised coming out in March, they do have a bereavement, like I think it's called like extensive bereavement or something like that, where, maybe anyway, but there is a diagnosis that has been added, but that is outside the scope of what I'm talking about right now. We will deal with that when the DSM-5 text revised comes out. So when you are distinguishing grief from a major depressive episode, it is helpful to consider that in grief, the predominant affect is feelings of emptiness and loss, while with major depressive episode, it's a persistent depressed mood and the individual inability to anticipate happiness or pleasure. So there is still like an element of hope, an ability to experience joy in grief. But of course, there is a grieving period, right, where that is less present, but that's a distinguishing factor between grief and a major depressive episode. The dysphoria in grief is likely to decrease in intensity over time and sometimes comes in waves. So for any of you who have had a loss, maybe a death, a breakup, a job loss, things like that. So these are pangs of grief, these waves. And these waves tend to be associated with thoughts or reminders of, again, the deceased, the ex, the, reminders of a job loss or something like that. So it's not just death, it's a general loss in terms of grief. So that's the dysphoria where grief is considered, and then a depressive mood of major depressive episode is more persistent and not necessarily tied to specific thoughts or preoccupations. So reminders of an individual, reminders of, again, like grief with loss of a vision of the future, a loss of hope, something like that, is distinctly different because it's connected to something, whereas a major depressive episode doesn't necessarily have to have a thought or anything connected to it. The pain of grief may be accompanied by positive emotions and humors that are uncharacteristic of pervasive unhappiness and misery characteristics of a major depressive episode. So again, the presence of things like positivity, humor, hope, those really aren't existing in a major depressive episode. And the thought content associated with grief generally features a preoccupation with thoughts and memories of the loss, rather than self-critical and pessimistic ruminations that are present or criteria meeting of a major depressive episode. In grief, self-esteem is generally preserved, whereas in a major depressive episode, feelings of worthlessness and self-loathing are very common. So you can see some of those distinguishing factors. If self-derogatory ideation is present in grief, it typically involves perceived failings with the person that they lost. So not visiting enough, not telling them, the person that they lost, how much they loved them. And I'm sorry that this is he or she, it should say they. If a bereaved individual thinks about death and dying, such thoughts are generally focused on the deceased, or again, the loss, and possibly about joining the deceased. So again, this could just be very passive on what it would be like. Whereas in a major depressive episode, such thoughts are focused on ending one's own life because of their feelings of worthlessness, undeserving of life, and inability to cope. So one is connected to another person. And then with a major depressive episode, it's more inherently linked to the person, to the individual who's experiencing it. So grief, kind of more externalized, major depressive episode, more internalized. So then there is the diagnosis of dysthymia. And the essential feature is the persistent depressive. So dysthymia is also called persistent depressive disorder. And this is a depressed mood that occurs for most of the day, for more days than not, for at least 2 years, or at least 1 year in children and adolescents. So the prevalence of this is 0.5%. And 1.5 for chronic major depressive disorder. So 0.5 for dysthymia, 1.5 for major depressive disorder. And then in terms of development and course, the dysthymia often has an early and insidious onset, so in childhood, adolescence, or early adult life, and is chronic by nature. In terms of risk and prognosis features, childhood risk factors involve parent loss or separation. So again, it can be having this disconnection that could inform or increase the risk of an individual developing dysthymia. And then a screening question for this are you almost always depressed? So it's this, like kind of low grade depression. It is baseline, whereas so this is the persistent mood that the person is just used to. They are in a depressive mood most of the time, at least for the last 2 years. Then there is premenstrual dysphoric disorder. So this was added to the DSM-5. I don't believe that this existed in the DSM-4 text revised. So this is for individuals with uteruses. So please make sure that you are screening this, because this is, I think it said something in here about women. So just please don't overlook trans men with this, or individuals who are non-binary who have a uterus. So it's about having a uterus and having a menstrual cycle. So the essential feature of premenstrual dysphoric disorder is the expression of mood lability, irritability, dysphoria, and anxiety symptoms that occur repeatedly during the premenstrual phase of the cycle and remit around the onset of menses or shortly thereafter. So this, however often this individual is experiencing their menstrual cycle, it has happened, these features, these symptoms are happening prior to menses, but then they dissipate. So it is, the cycle of this is pretty clear, but the diagnosis should only be made with these symptoms of dysphoria, experiences of dysphoria occurring with most periods for at least a year. So, you know, if it's month 2 and this person says, hey, I've been having a really difficult time with my menstrual cycle over the last couple of months, that diagnosis would be provisional. So this would be something that you would continue to assess. So remember what Dr. Francis says of going nice and slow, taking your time. Of course, we know that there are pressures from insurance companies. So that's where the DSM-5 has that provisional diagnosis, or they very well might meet diagnosis for another disorder, but this is something that basically needs to be assessed for a year, or once the person comes to you, they may have had a year of symptoms, but if they've only had 6 months of this, you have to wait another 6 months for this diagnosis. And then a screening question for this is, do you have lots of psychological and physical symptoms occurring around the time of your menstrual periods?